So I was asked to try to tell you the answer to the question, do we actually need a pediatric rapid response team national registry? And my initial and very short answer is absolutely yes. My a bit longer answer is yeah, but because it's a complex project, hence a complex answer. First, we need to consider the fact that the demand for rapid response teams continues to increase, with increased need to employ critical care teams to look after these patients and to support the ward staff, increased pressure on ICU bed, and most importantly, as we know, increased risk of complication, length of stay in the hospital, and mortality of these patients. This is unpublished data so far of ANZIC score, and it shows that in metropolitan, rural, and tertiary hospitals, all in adults, there's still ongoing increase in the med calls per 1,000 patient days. The graph on the right is showing that the similar rise in ICU admission post-med had reached a plateau in the same hospitals. So considering the consumption of resources and the effect on patients, we should aim to move from reactive to proactive data gathering. And the concept of big data allows for hypothesis generating rather than hypothesis testing data analysis. Computer analysis allows us to convert unstructured data to identified trends, and large volume of data can be congregated, thus make trend visible. This requires data from hundreds of sources, ICUs in this case, while it might not be visible in a single ICU. And it has the potential to represent the real world rather than local area. Here are some examples. So that's an example of high volume data, in this case over 270 hospitals in the US, and that's all adult data, and more than 280 cases of medical emergency calls. They looked at predictors for in-hospital mortality following a med call, and they came up with a prediction model with area under the ROC curve of 0.78. And on the graph on your right, you can see the predictive parameters, mainly systolic blood pressure, age, length of stay in the hospital prior to the med, and the respiratory rate. On the other graph, you can see that it actually is capturing risk in all sorts of hospitals, both small and big, metropolitan and central, teaching and non-teaching. Now, that doesn't mean that with the increased risk of death, they have to admit all these patients following a med call. But it does mean that a better discussion can be held either prior to the med call or during the med call to decide about potential redirection of care if the patient is ineligible to go to ICU, because we know this patient is much more likely to continue to deteriorate. Here's another example. So that's pediatric data from the US, over 3,600 med events in over 150 US hospitals with pediatrics. And you can see that despite the fact that only 6.1% of their patients actually needed intubation following the med, only 0.5% of their patients needed CPR, and it doesn't show here, but a very small proportion of the patients actually needed high-risk medication treatment, such as inotropes. They still admitted more than 50% of the patients following the med. The other thing that is interesting is that, as Felix mentioned, from the data we got, over 35% of these patients who had a med less than 24 hours prior to the med were transferred from ED, recovery, theater, or ICU. So that's a good indication to look at these trends and to say, well, we A, need to improve our triaging system, who's actually safe to go to the ward, and B, we should probably support the ward system to keep patients who don't need to go to ICU from going to ICU. We know going to ICU is a very expensive thing. My last example here, this is a trial to see whether or not the afferent lib, so the ward nurses, actually call a MET when they need it. Whether or not the overtired, understaffed night team are not calling as many METs as they should. So they looked at the MET calls between 1 a.m. and 6:59 a.m. in the morning. It's 25% of the day. Allegedly, it should have 25% of the MET calls. But as you can see, less than 3% of the hospitals actually got to the expected 25% of the MET calls during this survey between 1 a.m. and 6:59 a.m. Now, it's not only they didn't call the expected number of MET calls. At 7 a.m., there was a dramatic peak of MET calls, and these patients were much sicker than the patients who had MET call at 1 p.m. So this clearly shows that we need to increase the education and potentially the staffing in the wards overnight. They just don't utilize the system that we think is working from the ICU perspective. And as Daryl and Ronaldo told us already in 2012, we need a new paradigm. We don't need to be dragged by the data. We need to be proactive. We need to predict the risk. We need to prevent deterioration. We need a better way of planning what's good for our patients. The next advantage of a rapid response team registry is, after identifying trend and safety concern, is to understand where your center stands compared to others. And we all know the ANZIC's core data about CLABSI and about discharge after hours, and there's no reason we won't have that with rapid response teams. It also means that we will have data about things like education and governance in each center, so we'll be able to plot the minimal requirements we have for these centers. It's probably going to be different to a tertiary center compared to a rural center, but we need to know what's the minimum requirement we need. Again, the data will further assist us developing high-level governance, education of the efferent MET limb, clarifying the efficiency of our escalation pathways. Auditing, executive support, clinical governance, and education are key to success. Now, after I convince you we need it, we get to the problematic parts. So who should be included? I see 3 options. Please let me know if you find other options. The first one is a national registry, including the adult hospitals. The second one is only hospitals with pediatric ICU, so the ANZPIC registry. And the third one is all hospitals with pediatric patients who actually have a pediatric MET system. And there's a clear advantage to be included in a national registry with the huge volume of the adult MET patients, a much bigger volume of information, and we already discussed the fact that large volume of data can lead to hypothesis generating data rather than being dragged after the data that you're looking for. It is impossible to do that in the very small cohort of pediatric ICU registry. However, we do know that our patients are not the same as adult patients. We admit patients with severe comorbidities. We highly redirect care. And most importantly, we hardly have unexpected arrest in the ward. So this is not a good way to assess how good we are. While there's a clear advantage in allowing all pediatric centers to collect MET data, we need to remember that it's damn hard to compare apples to oranges. And apples must be compared to apples. And that rural centers which have a pediatric MET team should not really be compared to Westmead or to the Royal Children's. So we need to be clear, even within a registry, who's comparable to whom. Other complications to consider: funding, and who will actually be in charge of collecting the data and doing the analysis. Who's in charge of the data collection in each center? It's really easy at the Royal Children's Hospital. I'm not quite sure it's as easy in Mildura Base during the night. We aim to collect as much data as possible, but we don't really know which data is important to whom, and probably for a tertiary center it's different than to a rural center. And can we force people to collect data that they are not collecting to their own needs? So as Felix showed you, people were happy in Victoria to collect data for the trial on top of their data, but the question, if we continue with that, whether or not in 1 year or so, they will still be happy. So to summarize, yes, we need a registry. It is hypothesis generating rather than hypothesis testing opportunity. The potential to represent the real world without local bias, improve quality of care, escalation pathway governance, and identify projects requiring funding, and enable clarifying what are the minimal education and governance requirements. But we need to be very clear who's included in the registry. We will have to balance the advantages of big data and large volume of information to the need to compare similar centers. We need to talk about funding and what data to collect. Thank you.